Hey everyone, welcome. So glad you're joining us. Today we have Dr. Husain, who is a world-renowned laryngologist, and myself, my name is Molly. I'm a registered dietitian specializing in GERD, LPR. Inna also specializes in LPR. She has been published in so many studies and is a global leader in LPR, GERD, reflux. So we're going to be talking about something both of our patients really ask a lot of questions on and are really interested in understanding, which is what is the root cause of LPR, reflux, GERD? So we're going to be talking about how to understand different testing options and some potential root causes to be aware of.
Great. Thanks, Molly. And I just want to put a little shout out. You are also well renowned. So looking forward to this conversation.
Yeah, so excited to be chatting with you. It's always a pleasure.
Mhm.
I think one of the best places we could probably start would be just understanding what diagnostic testing is available. And, what are some diagnostic tests that you commonly use to identify the root cause of acid reflux so that we can determine the appropriate treatment plan?
Sure. So I think first off, I'm always surprised at how little workup most patients undergo. And I think part of that might just be that when we talk about reflux, most people will say, yeah, I've had it once in a while. And it's such a common type of thing. But really, when we're talking about like persistent symptoms or LPR type of symptoms, really trying to figure out what's triggering it is so important because we know our classic regimen of things like acid suppression just doesn't work well for LPR symptoms. So really trying to figure out why it's happening is like so important. So there actually are quite a few testing options that are available for patients. The one which can be, kind of annoying when I mention to patients is essentially the role of like the upper endoscopy. So most patients before they've come to see me, if they've been diagnosed with GERD, have had an upper endoscopy, which is the GI or the gastro doctor places a scope and looks at the esophagus and stomach. And I still somewhat consider this diagnostic, though it's not really the best test for mechanical reflux. I tell patients that an upper endoscopy to me is kind of like a physical exam of your GI system. Unfortunately, the GI doctor usually has to take you to a suite and put you under sedation in order to do that full physical exam. But that's kind of the utility of it, is we really want to get a sense of what the anatomy looks like. And we also want to make sure that there's nothing worrisome happening, right? So this is how we would first identify precancerous changes. In terms of diagnosis, I like the upper endoscopy for really helping, evaluate for things like H. pylori, which they can do on a biopsy directly of kind of the stomach tissue, and even allergic type of conditions. One of them is called eosinophilic esophagitis, which a lot of times the symptoms can kind of mimic what we're talking about when we talk about silent reflux or LPR. So I do think there's an important role that the upper endoscopy plays. That usually leaves patients with not a lot of information, though, right? So most of the time they'll find some inflammation, but where do I go from here? Didn't answer the question of why this was happening. So another test that I commonly order is something known as the barium esophagram. This is where you drink something known as barium with a moving X-ray behind you, and as you're drinking the X-ray, the fluoroscopy is going on, and we can see the barium going down. It helps to outline the esophagus, can look for things like esophageal dysmotility, can identify things like a hiatal hernia, which can contribute to reflux. And it also can just show us frank reflux without really any of those anatomical changes. And that to me usually suggests that the lower esophageal sphincter might be loose or weakening. So I find that that's one of the easiest tests to get to get completed for patients because it's readily available in most hospitals. It's somewhat non-invasive, right? So there's no catheters or discomfort. The barium doesn't taste great, but I usually start with that sort of workup before moving on to more kind of advanced diagnostic testing.
That's super helpful to know that there's other options, especially if someone had a, unremarkable endoscopy. Do you ever recommend, like, I know this may be more GI, but a pH impedance? Are there certain areas where you recommend someone to go see a GI for a pH impedance or a Bravo test?
Yeah, definitely. So I actually offer the 24-hour pH impedance test myself. And
Oh,
the
good.
reason I offer it myself is because it's a huge diagnostic tool for LPR. It's essentially what we call the gold standard for really diagnosing LPR. So when we talk about upper endoscopy and barium esophagram, we're looking for reflux in general. But there's always that question of, well, I have reflux. Is it really what's causing my symptoms, right? Because you can have lots of different things going on. So I use the 24-hour pH impedance probe, not as first line by any means. I mean, my first line is usually, diet, behavioral modifications, perhaps upper endoscopy, perhaps a barium esophagram, but I reserve the 24-hour pH impedance test for basically patients who are having persistent upper airway symptoms that I'm suspicious are caused by reflux. It is not a very comfortable test, so that's why we don't, you don't walk in the door and get it. We talk about it, but it really helps to identify if there is upward movement, and that's what the impedance kind of probes are looking for, and also whether that movement is acidic or not. So it can really leave you with a lot of information of, do you have reflux? Does it go all the way up to kind of the throat? And if it does, is it an acidic picture, a non-acidic, a mixed picture? And then there's also a component of that where you can do a correlation. So we can correlate the symptoms with the events and give more kind of probability that yes, reflux is probably contributing to your symptoms.
Yeah, that's hugely helpful. In terms of, diet and the way that we eat, there's also some root causes that I think, or not necessarily root causes, but some contributing factors that I think people should be aware of. I see a lot of people who maybe had the acid reflux triggers in excessive amounts in their diet before being diagnosed with LPR or GERD. So sometimes people will come to me and say, I was a waitress or a shift worker and I was drinking a lot of carbonation to stay awake. I was eating really, really late at night. These are all factors that could potentially be, contributing to your symptoms that could be really easy switches. So, when we think about nutrition, we really want to make sure we're thinking about what foods trigger reflux. That for a lot of people, it may be beverages like carbonation, alcohol, caffeine, especially if we're consuming these things in excess or late at night. If we are consuming really large meals late at night as well, which can happen if you're a shift worker, or if you also if you have disordered eating, that can be a root cause of acid reflux, is going too long in between meals or restricting and then having larger portions, or under eating in general. If your digestive system doesn't have enough nutrition to function well, our motility can slow down. Your body literally doesn't have the building blocks, the protein, the iron, B12 to build digestive enzymes and to function well. So 90% of individuals with disordered eating do have a functional digestive issue like acid reflux. So, potentially those factors can be contributing in some cases.
Definitely. Yeah. I mean, I think sometimes it's really hard because patients come in with like preconceived notions of what reflux is, right? Like, I don't eat spicy foods. Like, I don't eat fried foods. And then we have to kind of break it down into that, like, that's just like the tip of the iceberg, right? Like, that's the postcard statement. But what we're really talking about is like, what are you really eating and when? And have there been really any shifts recently? So I really I think that's great that you mentioned like the shift workers. I mean, we see that a lot. People who, work maybe at night and then they go to sleep right away, but they're also hungry. And so that I saw a lot of kind of symptom develop with like the intermittent fasting fad, right? Like the really high protein. And how do you get protein? Sometimes it's not in the most nutritious ways, right? And so we saw a lot of that with the high protein diets, and we know protein actually turns on the acid pumps in the stomach. And so we were seeing a lot of kind of acid reflux issues with that with regards to diet. It is not uncommon for beverages to trigger this. So not uncommonly have I come across patients who just started including one new drink. And the reason for that drink can be a variety of things, but it almost always has some sort of citrus, lemon, either a weight loss type of thing or a thinking lemon's going to get rid of their mucus thing, or but it's always this like citrus beverage and plus or minus carbonation, and it just eliminating that. I mean, it's kind of funny sometimes where we kind of a joke with the patient, like, can you just do me a favor and just like not drink this for a couple of weeks and let's see how you do. And sure enough, they always have some improvement.
Yeah, totally. Yeah, it can be the combination of carbonation, caffeine, plus or minus citric acid, like so many different things. So yeah, and then, in terms of other root causes that maybe wouldn't show up on a medical test, are there any potential other root causes that you see in your practice?
Yeah, I mean, unfortunately, stress, anxiety is really a big one. And what's really tricky about that is, for a certain extent, all of us have stress and anxiety. And these last couple of years have just been really hard, right? So that's kind of one of the ones that's a little bit harder to kind of tease apart, because most people will say, I do feel that. And then there's also the chicken or the egg, because now they may be having anxiety because of their symptoms. And so we talk about the kind of the biofeedback with, stress and anxiety makes people more vigilant, and hypervigilance then makes the vagus nerve get activated, which is then going to cause a lot of these referred symptoms. And so, where do you intervene, right? And so I'm frank with patients. I'm very honest, and I say, listen, life is stressful for most of us. Let's figure out what you need to help kind of reduce that kind of hypersensitivity of the vagus nerve. Is it spending more time with your family? Is it making candles? Is it,
Yeah.
getting acupuncture? Like, there are a lot of different ways that might help. Is it working with a therapist? And so we do, bring that into the discussion as well, about how there are physiological ways that stress actually creates reflux. And so that's definitely like a big one that I see. Another real big one is this idea of like medications and medication shifts, right? So goes along the lines of like also being ill. So upper respiratory infections, viral infections can trigger dysmotility, and this is seen in the GI literature. But also, if you think about when you get sick, most people get put on antibiotics and things, right? And that's going to really adjust and shift your microbiome. And we have research coming out about how that makes a difference in LPR symptomology as well. So, a lot of times I ask like about any new medications. Have you been on antibiotics recently? Have you been ill recently? If that could be triggering it.
Super important, and so glad that you're having this conversation with your patients. A huge part of what I do, in addition to, diet, nutrition, the way that you eat, is stress management, developing habits in your life that help you deal with the stress of life, because we're always going to have different things thrown at us. We can never control what happens to us. We can only control the tools and the systems and the habits that we have in place. And so really supporting yourself with things that bring you joy, like the candle making, or stress management, like, meditation, deep breathing, which in fact has been shown, diaphragmatic breathing has been shown to help enhance the pressure of the lower esophageal sphincter and prevent reflux. So, it goes hand in hand. And, on that vein, there's definitely things we can do besides removing things, but also thinking about things we can add in, especially if you've had maybe some post-antibiotic disruption to your microbiome. We really want to think about balancing our meals with all of the components that our digestive system needs to function. So that being, a fiber-rich carbohydrate like sweet potato, wild rice, quinoa, a whole grain type item, a protein food to support your gut, which is a muscle, and a variety of carbohydrate of fruits and vegetables, different colors, trying to rotate those. Someone with LPR may be choosing lower acid fruits like melons or bananas, brown pear, papaya, things like that, if they're sensitive in that area. But we want to think about not only that, but also omega-3 rich foods. So it's, salmon, walnuts, flaxseed, to support decreasing inflammation. So I talk a lot about nutrition in my practice, but also strategic supplementation. And I know we both talk about this, but I think it's really important to spread the awareness of alginates for people, because that can be game changing.
Yeah, I think for most of us who treat a lot of patients with LPR, I think really the use of acid suppression through proton pump inhibitors has really fallen out of favor. And I think it makes a lot of sense when you think about what proton pump inhibitors really do, which is reduce your stomach's ability to produce acid. Now, I always tell patients acid is in the stomach for a reason, right? It's there to really help you with digestion. And digestion is really important to help you absorb those really important nutrients and things like that. So when we chronically suppress that process, you're almost triggering further problems with, again, without getting at the root cause. Now, I am not anti PPI by any means. And I tell patients this all the time. I do have patients from time to time where I think they would really benefit from it. But most of the time, it's like a short course, right? It is we're going to do this for this amount of time while we are investigating, while we're making other changes to help give a little supplement. The reason I like alginate so much, and I think we're kind of on the same page here, is one, it doesn't really change anything about your natural digestive process in terms of turning anything off that you need. It really just helps create that mechanical barrier to help reduce mechanical reflux. And so, it's a great natural option. It's a great kind of tool that patients can use to help them along their journey. We all need a little bit of support from time to time, and what better way than something that doesn't really have side effects in order to do that. So I agree. I'm a fan of alginates as well.
Yeah, absolutely. Me too. Yeah, and I think that, really important. Can we talk about also with root causes, anatomical? Like, how often do you see anatomical root causes? What role does that play in, your medical intervention, and how do things change there?
Yeah, so really with regards to like anatomical changes, often I'm thinking about like the esophagus and things like hiatal hernias. There's not too much anatomical things with regards to the structure of the larynx or the throat that we really have any correlation that it predisposes to reflux. I don't know if that makes sense. The one caveat I will tell you to that is really obstructive sleep apnea. So we know obstructive sleep apnea, which is due to obstruction in either, the nose and the throat area, can predispose to reflux events. So that's one anatomical finding that I often come when I'm scoping patients is I ask them, by the way, how's your sleep? Does your spouse say you snore a lot? Do you think you're having apnea? Because I think you might have sleep apnea, and that actually might be the root cause of your reflux, right? Especially nighttime reflux. So that's one kind of head and neck type of anatomical change I might see. In terms of the esophagus itself, I will tell you when we start looking for things, we do find things. And so esophageal dysmotility is a really big one that I find a lot. We do find hiatal hernias even in patients who've had upper endoscopies, and that was not mentioned. It can be tricky to find things like that, right? Because upper endoscopy is not you're sedated, you're laying flat, you're not eating or drinking. When we test the system with like a barium esophagram, oftentimes we can find things like the hiatal hernia, which again, patients didn't even know they had. And so I do often find kind of anatomical things that are happening that could be contributing to their symptoms.
Yeah, yeah, great. I think that the barium swallow is super helpful. How does the hiatal hernia change your treatment plan, or the esophageal dysmotility? How do they change like your treatment plan?
Yeah, so there's a little bit of selection bias essentially in terms of the patients that I see, because most of the time patients come to see me or ENT or laryngology when there's persistence of symptoms, right? So we don't see everybody who intermittently has reflux or silent reflux type of symptoms. We usually see the persistent patients. So our yield of finding something anatomical is likely going to be a little bit higher because of that selection bias. But when I find a hiatal hernia, one thing is kind of how I counsel patients. So I have to tell them, look, you have a structural reason for being more predisposed to reflux than a person without it. So what that means is that when we give diet recommendations, there's really a physiological reasons these diet modifications or how you eat and drink will impact you, right? Because when we see the hiatal hernia, I can say, listen, you're going to have a big meal. This hiatal hernia is going to play, right? It's going to activate and it's going to give you reflux. If we found that you did not have a hiatal hernia, yeah, maybe you can get away with some of those heavy meals and things like that. But I think it's more just to help patients understand, like, why are we making these diet changes? It's because you have this anatomical reason that predisposes you to reflux.
Yes, I'm really glad you mentioned how you eat too. This reminds me of, one of my patients who changing her mealtime hygiene was the most important thing that she did. She was struggling with reflux,
Mhm.
and she had a hernia. But even a bigger game changer than removing the triggers was just slowing down at meal times, small sips, sometimes using water washes, just like sips of water, but not overfilling her stomach with water during the meal, and really chewing
Right.
food well. And all of this was, in addition to diaphragmatic breathing around her meal times, really slowing down was like one of the biggest things that helped.
Right. we've talked about that, like enjoy your meal.
Yeah,
Take the time.
yeah, absolutely. Well, this has been so helpful. Thank you so much. Is there anything
Yeah,
else
of
you want to
course.
share about, root causes or anything that we didn't get
Yeah,
to?
I mean, I would just let the kind of viewer know that, there are definitely a lot of tests, and there's even more than we've really gotten into. We don't have too much more time, but really kind of bring it up, right? So I think sometimes, again, advocating for yourself and saying, is there any other testing I can do? Yes, there is. It might not be offered to you, but you can always ask about it.
Amazing. Yeah, thank you so much. And it was great to
Yeah, of
see
course. Thanks so
you.
much, Molly. Nice to see you as well.
I'll talk to you
Bye.
soon. All right, bye.